Thank you very much, Alexis, Marie, and Teresa, for joining us for this interview about your clinical practice improvement project, Is It Delirium? Differentiating Delirium, Dementia, and Depression. We're hoping that today we can have a little conversation about how it is that you embarked upon this project and what it is that you've taken away from this experience. So what I'd like to do is ask you first if you would each introduce yourselves so that folks can get to know your voice, maybe starting with Alexis, following with Marie, and then Teresa.
Hi, Ellie. This is Alexis Welch, and I'm the Dean of Health Sciences and Nursing at Lenoir Community College, and we're glad to be with you today.
Thanks so much.
Hi, I'm Marie Hudson, and I'm an education specialist here at Lenoir Memorial. I've been in the education department for 6 years.
Welcome, Marie. And from talking with you earlier, I understand you also serve as a clinical instructor for one of the university nursing programs?
I do. I have first semester nursing students in East Carolina on Mondays. So I still do some clinical. I still get up on the floor and get to play nurse.
Okay.
One of the favorite parts of my job.
I love that. Okay. And then Teresa, tell us a little bit about you.
And my name is Teresa Sumner. I'm the quality coordinator, and what that means is I look at the core measures, the quality of care that we're given to our patients. And I have an extensive long-term care background and working with the geriatric population, so I serve as a resource to the hospital when there's like geriatric issues that might come up, or if they have a question of how to deal with a certain patient or diagnosis. So I've been in quality now for about 3 years, but like I said, I've worked in long-term care and subacute care.
Great. Well, again, thank you so much for joining us. What I'd like to do next is ask you to tell us a little bit about your project, how you decided what topic to pursue, and a little bit about what you set out to accomplish.
We had our CPIP group started out with 3 champions, and that was the 3 people you hear today, Marie, Alexis, and myself. And ours is a little bit unusual, I guess, because most people just do a project within their organization, but we span across 2 different organizations with hospitals, of course, and then the community college, so where we're teaching our new nurses and nursing assistants. Our group is a little bit unusual, not only in that we work in different organizations, but even though we've known each other for decades, and we've known each other's capabilities and our leadership styles, and I think that helped a lot with our project. We really wanted to know, what can we do? What kind of project could we do that would make a difference in the community, and how would we, reach out to different caregivers, whether they were new nursing students, whether they were nurses who were working in the hospital, and nurses in other care areas. We did. It's worked out well to have each other to work with.
So one of the things that I hear you saying is you're 3 nursing leaders who are deeply embedded in your community, and in part because of the strength of your relationships, you were able to think about what might you do that would benefit multiple stakeholders, not just one.
Correct.
Great.
And we're our clinical partners with LCC. Not only in just having our clinical, their clinical experiences here, but we also participate in some of their orientation to the hospital.
That's just terrific. I'd be very interested in hearing you talk a little bit more about how you chose the specific target for your project.
When we first looked at what type of project we could do to make a difference, Marie went and talked to our Vice President of Nursing to ask her if she had any ideas, what were some concerns that she had, so that we could really make this a valuable project for our organization. And it seemed to keep coming up a recurring theme as people had difficulty in knowing how to recognize all those nuances in geriatric care. Most of our population is geriatrics, and although most nurses do not see themselves as geriatric nurses, they really are. So we wanted to increase their knowledge and look at those things. And during that same time, we had a patient concern. The family member had a concern about how her mother was taken care of, recognizing the symptoms of when she became confused, and we thought that was just a good platform to build off of. We did So we decided on delirium and how to increase the staff's knowledge and ability to perform a little assessment and develop some individualized interventions for these patients while they were in acute care. I think one of the things that really got us is when we started looking at delirium, and some of these statistics are terrible about how many people leave the hospital with delirium, you know, the prolonged hospitalization, even the increase in death. So we decided we had picked the right project.
Very good. So I agree with you. I just am stunned by how notable those statistics are about increased risk of death or other untoward outcomes. So can you talk with me a little bit more about the CPIP outcomes that you were particularly interested in trying to address?
I think the outcome that we really were interested in was better care of our patients and more knowledge for our nurses. And we also wanted to increase patient safety and customer satisfaction.
Mm-hmm. One of the things that I thought was really notable was that you identified outcomes for both the patients as well as for the staff. And I know that you mentioned earlier that you first approached the Vice President for Nursing to get her take on what the priorities would be. And you also used patient concern that had been raised. How did you approach the staff to understand what staff level outcomes you were interested in?
Well, we shared this with the nursing leadership in our rehab therapy group and our respiratory therapy group, and asked them to start with what were some of the issues that they felt like were coming up. And just through basic, you know, restraint review and those other things, people just became very frustrated in how to manage the behaviors of a person who has delirium. We're not really focusing on let's identify what it is, but how do we manage the behaviors? And that was an interesting piece, I think, for us to look at, that there was kind of a disconnect between, okay, I want to treat the behaviors and not so much looking at let's do an assessment to see what's causing the behaviors.
Very interesting. So on the one hand, it wasn't hard to get consensus that this is a problem, but you had a little bit of work to do to help people think about looking beneath the surface of the problem a bit.
So the other piece to that, Ellie, is that we, with Marie and Teresa over here in the hospital, they were able to get buy-in from the nurse managers.
Uh-huh.
And on my end, I got buy-in from the nursing faculty.
So tell us a little bit more about that.
Well, knowing that we have a geriatric population and it's growing exponentially, and we agreed on the topic of delirium, we felt like if we could start this particular concept in the School of Nursing, then the students were so much more prepared to care for a patient in the clinical area if delirium was a problem.
Very good, very good. So I guess to sort of recap what I've heard you say, I'm now thinking about the 8-step process that we use, and you identified the problem through a number of different venues, talking with the chief nursing officer in your main clinical partner area, looking at the evidence a little bit, and talking with individual staff members as well as the nurse managers and faculty who were involved in supervising students in these areas. Is that right?
Correct.
Okay. I wonder if you could talk a little bit about how it is that you used evidence and how the approaches that you took to looking at the evidence are similar or different to what you've done in other projects.
Well, I think one of the things that we did is, you know, we had you guys there to kind of guide us, and you had a variety of experiences with geriatric patients, and I think that we were able to draw on those, and I think some of the anecdotal and kind of activities that we used were really good. You know, we kind of borrowed on your expert opinion and then also some of the experiences that we had, but I think one of the things that really helped us with the interventions was how to make these classes interesting, how to help people learn, and how to engage the staff, you know, looking at case studies. And when we actually did our patient for our in-service, what we actually did was we used a real-life patient that I had actually helped with and helped the staff work through the issues with the patient. It was very Sherlock Holmes in trying to figure out what to do for this patient. So we just looked at interventions that would fit within our facility. What are things that we could really do? You know, we can always do care plans, always provide education. Those were the kind of interventions that we looked at. And I think for me, Marie and the staff development had already started doing this, but just the things that we did, like doing the way we did the pre-test and the post-test. You know, doing that fun thing we write it on the board.
They were non-threatening to the participants.
So that really allowed you to understand what was on everyone's mind and pretty quickly correct if you needed to do additional education or whatnot.
Yeah, it was very interesting because we have a bunch of cards filled out. We may have had 30 cards filled out, maybe had 25 people. People wanted extra cards so that they could put things down. And there was a lot of discussion as they were writing on the board where they thought delirium, depression, and dementia all went. And they were teaching each other. It was very interactive. And I got a lot out of that as far as going through the whole GNIE process, how to make it more interactive, more engaging, learning some of that, teaching yourself. I mean, I don't even think they realized they were teaching each other, but that's what was going on.
So cooperative learning was a big feature of how you implemented some of these approaches to raising awareness about delirium and what to do once you realized that that may be a problem of your patient.
Right. It was really good to have the case study because everybody recognized those type of patients. They were able to. We didn't really have any issues with people being willing to be part of the skits. I mean, we even had people who said, "I don't do skits," and they were there doing and did a great job. And there was the pre and post test, and there was the case study and the skit. Then Marie had presented a PowerPoint, so it was the information came 4 or 5, and within that hour came in 4 or 5 different ways. And I really felt like people left understanding the difference between the three, but really with a good focus on how to identify delirium.
Wonderful. So
The last part of the class was that we went back to the board where they had written in the different columns the adjectives that they thought were delirium, depression, dementia, and we revisited that to see, you know, what their understanding was. So it was very interactive, and I just think everybody enjoyed it.
well, that's fantastic. So I guess I'm interested in knowing you had an early success with some of the educational strategies that you've just described. What's really remarkable to me is you seem to have really been successful in sustaining this type of education. So I wonder if you could talk a little bit about, since that first set of educational sessions you had, what are you doing now to keep this sustained, a part of the practice at Lenoir Memorial Hospital and a part of the routine teaching of nursing students and new nurses?
Well, our goal is to continue doing the classes with the nursing students. I think we had the freshman and senior class last year, so it's time for us to revisit that again with the new classes that are coming on. As we said, we've implemented into the new nurse orientation, trying to get that out there, doing some of the students. One that we also, I did it with the hospitalists here. Our group of hospitalists are excellent, and they see probably about 60-75% of our patients. We've done some work with them on educating them, and I have seen some successes where I do see them actually looking and, you know, writing in their notes that they are looking at delirium and looking at those kind of things.
Oh, can I get you to pause there for a moment and talk just a little bit more about how you approached the hospitalists initially and what were some early responses they had?
Well, I actually had a working relationship with the chair of that group because, number one, he's 2 doors down from me right here, and he does the core measures. I have a lot of conversations with him about core measures, and I told him that we were doing a project on delirium and that since he had a large group of the physicians, would he allow me to come and talk to them and just have some conversations about that? And he said, well, I think most physicians, you know how to do delirium assessments and do that. I said, well, I appreciate that, but I really would like to come to the meeting. And we met, and I probably talked 30 minutes, and we talked about different things, the type of presentations the patient had, what our goals were. You know, our goal is to figure out, you know, if they got a low sodium, let's treat it. You know, if they've got an underlying infection, let's treat it. That decreases the length of stay for them.
Mm-hmm.
Also decreases all the devices and the cost for taking care of these patients. And that seemed to kind of turn them around when they saw how much of an impact they could have.
Wow. So did you agree on one particular measure of delirium, or do you approach delirium measurement as in a more clinical manner?
I think we need to define that a little bit.
I believe it was more of a clinical nature.
Okay. And I ask that question because some people are very keen on having a standardized assessment used, such as a confusion assessment method or one of the other instruments that are out there, such as a NuDesk, whereas others think, oh, if we can just teach people what delirium looks like and what its key presenting features are, using guidelines like are in the DSM-4, that will actually be more successful.
We actually used a 4-question format that's on our Connect card.
Uh-huh.
Has there been an acute change or fluctuation in mental status? Does the patient have inattention? Is there disorganized thinking and altered level of consciousness? And then on our little handout that the staff have, it talks about agitated delirium, hypodelirium, mixed delirium, and then we give them some prevention tips on this. So they're actually looking at 4 simple questions. So if you have a relationship with that patient, you'll definitely pick up acute changes and some of those kind of things. And we defined what each one of these causative factors is, or one of these symptoms.
Got it. And that sort of gives you a basis for consistent communication with the hospitalists and the other nurses.
It does, and I think the simpler the better. I mean, I love forms. I mean, I like the Brady scale. I like the Hendricks and Borsfall scales. But sometimes for the nurses, they just need something practical, easy to get to, and simple to determine what's going on with their patient.
Simple is good. What I'd like to do now is turn the conversation a little bit to practice change barriers. You've had a real success here, but I have to believe that there may have been some stumbling blocks along the way. Can you talk about any barriers that you encountered and what it is that you did to overcome them?
Well, we believe the greatest barrier was time constraints for participants. We did have nurse manager buy-in, but I don't think we had not one nurse manager to come.
No, they did.
Oh, they did.
They came to the first group.
Okay, so they did come. Nurse managers did come, so they set the example. But it's really hard for staff to leave the floor, leave their patient assignment with somebody else, and participate in the 1-hour program. And the hour went by very quickly. So time constraints was our number one. The second barrier was leadership commitment.
To getting staff down there.
To getting staff to participate. They can't make them come to a workshop.
Mm-hmm.
The numbers have escaped me as to how many participants we had, but and they were interdisciplinary. It was not just nursing, registered nurses or LPNs. They were nursing assistants. We had physical therapy.
Dietitian.
We had a dietitian present, so it was interdisciplinary. So in addition to time constraints and leadership commitment, we felt like that another barrier was engaging frontline staff. You want to talk about that a little bit?
Just trying to get staff to see, what's in it for them, how what they do affects the patient, trying to get them to take a minute. From what I was talking about earlier, is they're looking at how can I fix the behaviors or mitigate the behaviors and not so much looking at the causative. And I think that's sometimes hard for some nurses. They get out there, they're into the doing and not really the, learning or not valuing why they're assessing a patient.
So how did you manage that challenge?
Well, we did set up a situation in which we would serve as consultants.
Mm-hmm.
I've done a couple consulting visits with patients who they were having issues with. We also have a safety ad hoc team here.
Uh-huh.
Because we do have, there's an issue with mental health in North Carolina, and the EDs are holding a lot of patients, and we're holding a lot of patients trying to get them medically stable up on the nursing floors. And then not only do they have dementia, some of them have depression or they're psychotic, so you've got all those kind of things going on. So I do participate with those patients as well. One of the things that's really got us in looking at the practice change barriers is, ever since we completed this, we were in our window for Joint Commission.
Uh-huh.
There's been a lot of focus on a lot of things, but we have passed our Joint Commission survey with the best one we've ever had, so we're kind of ready now to move on and go back and amp up some things that we want to do for the delirium education.
Sure. We always live in a land of competing priorities, right?
Exactly.
Yeah.
But we've also had some good stories that have been told to us after the workshop has after we did those series of multiple workshops. And that is, nurses have actually said that they've encountered such a thing as delirium with their patient, and those that participate in the workshop left that workshop knowing exactly how to identify and what to implement to turn it around. And we've had some real life stories of that they actually did that.
I'm told that there's nothing like a good story to motivate people. And so I don't know if you can call to mind one of those stories that other people might be able to relate to, or if it's too hard to just call one up right now.
Well, there actually was one situation, there were kind of two that were similar, but this was one that the staff was concerned about the patient. The patient had Alzheimer's, was staying at home, had not eaten, very concerned about the nutrition, feeling that nutrition issues were a problem. So they called me and I went up there, and the patient actually had started out with very good pre-albumins and albumins, and came in, and the time she was in the hospital, she had nutritionally, she was malnourished. And they just needed some help in having somebody come behind them, kind of give a okay to what they thought and what they said, and they were able to handle the situation. And it wasn't for us to go up there and fix the situation. Just wanted some kind of clinical or expert backup that what they had identified was great, and I thought that was awesome.
Absolutely. I think, as you mentioned earlier, sometimes you get so focused on the things you need to do to complete your task for to get through the shift that it's hard to step back and take a longer term look at what's going on, and it sounds like you were able to help them with that.
Ellie, I have another story in the community. You know, I work part-time, and I got a call one evening about a geriatric patient in a facility, 91 years old, and they wanted to know if I'd come by. Well, it was just as clear as water that it was delirium. So I was able to educate the family members there. I made a call to 911. She was brought to LMH, and she only stayed 2 nights, and it was turned around very quickly. And she's back doing well, ambulatory. She couldn't walk when she left home. It was just a pretty story. Oh,
that's remarkable, sort of how early intervention can really make a difference, because in someone that old, you could imagine things going quite differently if you hadn't been able to recognize the delirium and intervene so quickly.
This lady knows me by my nickname, so she told everybody at LMH that Lexi is the reason she was over here.
Oh my!
I know it's Lexi, so
I love that. I love that. Well, let me turn the conversation a little bit to things like data collection and outcomes from this project. I know one of the strengths of your group is that you have Teresa there, who is someone who's very comfortable in looking at data and managing data and thinking about outcomes. So can you talk a little bit about what approaches you took to data collection and outcome assessment as you were working on this project?
Well, one of the things we get, you know, the government requires HCAPS reporting, so we get that information on, which is the customer service piece, we get that on a pretty regular basis. What we could do, and it's a little multifocal here, because we had, not only do we have the delirium education, but we also started a new hourly rounding process to, you know, check our patients to make sure they don't have any needs. And we've seen a great increase in our customer service scores, especially in the realm of nursing. Assessment, did the nurse, you know, speak to you, did they talk to you about medication? So we've seen a great increase in that. So that we do feel like has had some impact.
Very good.
The falls program, one of the things that we've looked at, is also multifocal too, and looking at falls, we look at falls with injury, and when we say injury, we mean anything. If they had an abrasion, a skin tear, we do look at that. And our falls with injury have greatly decreased as well, but we also have a great safe patient handling program here too. So I think that it takes a lot of different means and methods when you focus on something to make changes.
Sure. And so one of the things I hear you saying is you've used data that are being collected for other purposes, such as the publicly reported quality indicators, and then trying to interpret them through the lens of some of the practice change that you've been involved with.
Right.
So as you think, you've mentioned some of the outcomes that you've seen that include earlier recognition of delirium, and you think that probably relates to other important outcomes such as reductions in length of stay or decreased risk of other important geriatric syndromes such as falls with injury. Are there other outcomes that you think of as being attributable to this project?
We would really kind of like to maybe start looking too at restraint use.
Aha.
Take that a little bit and see if our use of restraint has decreased, and maybe even go in a little more depth and see why the restraint was applied and was it related to a delirium episode. That's maybe for this next coming up year something we might want to look at.
It sounds like a really useful indicator to look at to me. In some groups that we've worked with around the issue of delirium, people have mentioned sitter use as an important outcome that some are starting to look at. Do you all use sitters at all in management of people with delirium or other neuropsych problems?
We do not. What we actually do is all of our beds are equipped with bed alarms.
Mm-hmm.
Alarms. We move folks closer to the desk. We ask families to stay with patients. We look at those things that maybe agitate patients, looking at all the pieces of the environment, but we have not got into the use of sitters. I mean, we're a community hospital, we're rural, and that can be very expensive.
Yes, indeed. Yes, indeed. Well, that's, I think, a concern that a lot of people have, and what a wonderful thing that you're able to engage family in the way that you describe. I was also impressed as I listened to you that you included family education as part of your work here, I gather, on a case-by-case basis. So I guess I just have two other topics that I'd like to explore. One is the sustainability of teaching nurses and other staff about delirium recognition, and also having an organized approach to delirium management. What plans do you have for sustaining the approaches that you've taken and found successful?
Well, from a college perspective, the summer course that the ADN students are involved or engaged in is more or less focused on mental health issues and illnesses. So we will continue to educate or engage those students in delirium during the summer semester.
Mm-hmm.
And for our practical nurses, it will be the same. It will be the summer semester because they are working with geriatrics in the summer semester very heavily, as they did in their first semester. So they know a little bit more in that summer semester or summer session.
So that's remarkable that you've got both the practical nursing students and the RN students involved in this type of training.
And I have asked, we have a new nurse that's over our nursing assistant program in GNIE, and I have asked her if we could start making those presentations to those students, but we've not connected yet, but that's my goal.
Oh, that's fantastic. Again, each member of the nursing team sort of being on the same page with respect to things to pay attention to as well as approach skills. I guess the last question I'm interested in hearing you talk about are your next steps in this. Sometimes we have participants say they just want to focus in more depth on a given topic. Other times we hear from people that this process, this 8-step process that we asked you to use in implementation of evidence-based approaches transfers on to other to the management of other clinical problems that come your way. So I'd love to hear from each one of you about your thoughts about what are your next steps in implementing evidence in care of older adults.
What I think one of the things is we have a step process here, which is our career laddering process, where the bedside nurse has an interest in something clinical that she wants or he wants to see, have a change in practice pattern, or just to look to see what is the current practice pattern. It's called STEPS, Striving Toward Excellence in Practice. And we have not been able to, I've been begging, I've been actually trying to get someone to take this project on, and it is overwhelming, you know, to take it on in a step to look at maybe on their floor, could you take your restraint data, your HCAP scores, work with your staff on the delirium assessment, and keeping it simple, doing the education, being able to see if you're impacting length of stay. So we're still working on that portion of it. But I do have to say, one of the things that Alexis brought up was that in the outcomes, and we didn't mention this a few minutes ago, is we were just amazed at how engaged staff were in this workshop and how eager they were to learn about something that they've seen all the time. I mean, they could all easily recall a patient who has delirium, and there was just so much fun and excitement in there. And I just thought there was so much for them to take away and something that we took away. So I think for our next steps, we're going to continue to do those type of things, and maybe looking at a way to present the information. Maybe we could do a DVD and have it on our health streams, or maybe we could do some shortened classes, some things like that to make it available for everyone. So, we're done with our joint commission process, so now we have time to move on to some of those things that we want to fine tune.
Excellent if we would do one of our classes and actually videotape the class. We have a closed system here on video on demand, and we could get it on that, and then nurses would have access to the class 24/7. So that would be good. That would help with educating when they couldn't maybe leave their patients. So that would be a good thing to do.
They have to use every bit of technology now, because that's what all these newer nurses who are coming out, they're used to technology. They're used to, it's not a bother to them to sit there and watch an iPod cast or a podcast. I mean, so they're used to this type of learning. So we're going to try every avenue to have everybody, something for everybody.
Well, I'm just so excited to hear the energy in your voices concerning this very difficult problem. And as I mentioned before we started the broadcast, I'm hopeful that there's a way that we can continue to partner with you, perhaps through our Geriatric Education Center, because delirium recognition and management has been a focus there as well. So as we start to develop some materials, we'd love to share them with you and see if there's a way that we could learn together about what are some of the best ways to get recognition and management of delirium done in an evidence-based way across a whole variety of care settings. So I'm glad you're in a position where you can begin to return to this and think about what some next steps might be.
I don't know if we, during our project, if it had been approved or not during the presentation on that final day, we were actually able to get AHEC continuing hour for our class for all RNs and LPNs.
Oh, how wonderful.
And I think that was good, because not only do they get to go and they learn valuable information to take care of their patients, but they also get to meet the state board requirements of the continuing education.
Absolutely. No, critically important, and very exciting for me to hear you reach out to those other resources that can really amplify your impact.
I think anytime you have something that's sanctioned by the Board of Nursing that gives you continuing education credit, I think it leads a little bit more credence to how important the problem is, how important this knowledge is. So it was just a win-win for everybody.
Well, this has been fantastic. So I've sort of run through the questions that I wanted to focus on during our time together. I wonder if each of you have something that you'd like to make sure that we pay attention to before we draw this to a close.
I would encourage any nurse, faculty, staff nurse, a nurse in leadership positions to participate in the SIP project with Duke's GNIE constituents. It's probably one of the most academic, research-oriented course and program that I have ever been involved in. There's a lot of satisfaction that the three of us, and I can't speak for them, but I think I can say this truthfully, that we've all, it's all been worth our time, effort, and energy, and it's been invigorating to us. I mean, we have been excited about this, and we thoroughly enjoyed doing it, and never did we dread, oh my gosh, it's another class. And when you think about the outcome is it's bettering the quality of care of a patient, then that's what we're all about.
Well, I'm really happy to hear that that's how you receive things, because that was certainly our intention. Marie or Teresa, any other last thoughts before we draw this to a close?
For me, I thought it was just very energizing for me personally as a nurse and for someone who deals, as a resource for the hospital. As Lexi said, the whole research focused environment was just excellent, and it just gave me something that I needed personally as a nurse, not only professionally, but for myself to increase my knowledge. I really enjoyed learning the different innovations of teaching. I think I would have never thought of putting so many different activities in one education session, and I would have never thought we had that. Number one, we could do it in a time frame, and number two, that we'd have such a great response and that people took away so much. That was just amazing to me. So I really do appreciate that opportunity, and I'm glad Alexis brought that to our community.
And this is Marie. I really enjoyed the classes that we went to. Everybody was so professional, and it was just a growing experience for myself. I really enjoyed it, and I was able to bring it back and put it to use in our organization. And it just means so much when you can do that, and you can see how it affects the care of your patients. So it was I just really enjoyed it.
Ellie, the other piece, this is Lexi again, the other piece is that the participants did evaluate this 1 hour presentation, and they were all the evaluations were just top notch in their satisfaction.
Well, again, just a real testament to the hard work that you all have put in sort of taking a whole variety of ideas and pieces of evidence and putting it together in a package that fits the need that you see in your community. So I really have my hat off to you, as does our entire team, for the incredible leadership that you've displayed here.